discussing the case presentation of CA larynx. Okay, and we'll be just saying the important points, like how to go about it if you get it as a case, and like what are the common Viva questions that you are likely to be asked. So we'll go about it, and let's be clear on that. Like most commonly, you will be getting serum squamous as your case, long case, followed by thyroid, and then followed by CA oral cavity. If you're very, I'll say, unlucky, then you'll get this CA larynx wala case. So it's better that you read up the basics about it. And similar, that is growth in the larynx or growth hypopharyngeal mass. This can be given to you as a short case also. Okay, and similar kind of patient can be given to you as a ward round operated patient, and your whole Viva will go upon CA larynx only. Okay, so it's important topic. It cannot be left behind. Okay, so let's start with today's session. I'll request Dr. Sridhar to go ahead with the presentation, please.
Okay, sir. Okay. So I'll start, sir.
Great. Go ahead.
Hello.
Go ahead, bhai.
Yeah. So, 65 years old male patient, Hindu by religion, formerly a rickshaw puller, resident of Mumbai, and come here with primary complaints of last months and breathing difficulty since last 2 months. Come to HOPI, change in voice is just insidious in and which was gradually progressive and hoarsened throughout the day with no elevating or relieving factors. Breathing difficulty which was insidious in onset and gradually progressive and initially associated with the sternus work and worsened since the last 2 days during rest and with no relieving rest. A no history of difficulty during swallowing, pain while swallowing, no history of throat pain, foreign body, no history of voice abuse, chronic cough, blood in of evening rise of temperature, night sweat, no history of neck swelling, restricted neck movements, no history of any appetite, no history of hearing, complaint, no history of everything, and no complaints. No history of diabetes, TB.
Sridhar, your audio is breaking. Can you just disconnect your earphones and again connect it once? The audio is breaking in between.
1 second.
एक बार just change it once.
Is it audible?
Yeah.
Hello?
Ji, you are audible now.
Better, sir?
Better.
Yeah. So, come to past history, no history of hypertension and on treatment since past 5 months, and no history of diabetes, TB, bronchial asthma, and no history of any previous surgery or hospitalization. Come to personal history, he's a chronic BD smoker since last 40 years and 10 BDs per day, up to 20 packages. And it is stopped since last 2 months back. And appetite is normal, mixed diet, bowel normal, bladder normal, and sleep is disturbed because of the respiratory distress. Of the family history, no significant history in the family members.
Okay, so till the history you have taken, so what do you think growth of which place are you dealing with? Sridhar?
Hello, sir.
Aji, till the history that you have taken till now, what do you think, what kind of growth are you dealing with? Can you go back to the HOPI slide once? Yeah. The first slide.
1 second, sir. 1 second, sir, please.
Haan ji.
1 second, sir.
Okay. No issue. Aram sir.
Actually, Hello, sir. Yeah.
हाँ जी,
Yes, sir.
go back to go to the first slide.
हाँ सर.
हाँ, enlarge करो, full screen करो. हाँ, ठीक. So the history which you have taken, what do you think? What kind of primary growth कहाँ पे है?
Sir, change in voice as well as the breathing difficulty. So most probably the swelling or growth will be in the glottis part.
Glottis. So basically, what if in the other words, I would like to frame the question that you all know that there are three subsides of larynx. One is supraglottis, then is glottis,
Yes.
and third is subglottis. So for the glottis,
Yes, sir.
the presentation is change of voice, right?
Yes, sir. Yes,
Just a minute, I'll take a break. Guys, abhi audio and video is clear to everyone?
Yes, it's clear.
Yeah, thank you. Okay, so we all see that there are three subsides. We just saw them. For glottis, the presentation is dysphonia. Therefore, the patient presents to us earlier, and therefore the prognosis is better. Okay, so remember this line. This can be framed in all three ways. That at which subside malignancy has a better prognosis and why. Okay, and similarly for supraglottis, the patient will complain of dysphagia and difficulty in swallowing, these kind of things. Okay, so move ahead to the second slide here. यहाँ पे note down the second question of Viva, that is they will ask you parts of supraglottis, parts of glottis, parts of subglottis. Okay, so you should remember this thing. Okay, so second thing I would like to tell you over here is like when we have this dysphagia, presenting complaints अगर dysphagia है, so for dysphagia you have to ask whether the obstruction is more to solids or more to liquids. Okay, so obstruction to dysphagia to solid, this generally indicates that there is an obstructive lesion towards in the pathway, whereas for liquid first or liquid more, they generally they might hint towards some neuromuscular kind of disorder. Okay, these two things you have to remember. Okay, so after change of voice, you have mentioned that the change of voice is constant throughout the day. So is there any significance of diurnal variation of voice?
Yes, sir. There are. Actually, if the patient is complains of any kind of laryngitis, the symptoms will be worse at morning and it get better by evening, as well as any history of laryngeal edema that will be worse at morning, but it will get improved by evening.
Why is it that in laryngitis the problem is more in the morning and as the day progresses the patient improves? Do you have any explanation for that?
Sir, basically that edema only, sir.
Laryngitis generally
overnight when the patient is sleeping, there will be edema.
In laryngitis generally there is pooling of secretion which takes place.
Okay, sir.
There is pooling of secretion basically which tends to occur overnight. So when the patient wakes up, so he wakes up with that heavy voice. Okay, and as the day progresses, that pooling goes off slowly. So he might give you this history that as the day progresses, I'm having betterment in my voice. Okay, so you have no aggravating or relieving factors. Come to the next slide. Okay, breathing difficulty you have mentioned. Okay, so don't mention any symptoms which does not have any explanation. Similarly, like in the squamous case we said, so whatever you say, you should have an explanation for that. Why have you asked that thing? Why have you done this thing? Okay, so doctor, both of these things you have told till now. Why do you say it is a laryngeal pathology? Why couldn't it be a thyroid pathology? It's a very common question in my mind.
Yeah, usually thyroid pathology, it comes along with in thyroid neck swelling here. But there is no history of any neck swelling here. So,
Dr. Ashish, still it's not audible to you?
Sir, his voice is breaking. Yours is good, but his voice is breaking.
Okay. Sriram, एक बार I request थोड़ा सा location if you could make it better, जहाँ से थोड़ा सा net अच्छा आ रहा हो, in case it's possible. There is no surround sound, but this little bit break is there. Okay, so in case possible, थोड़ा net.
How is it now?
To me it's coming good. Okay, so if possible, use your earphones if you are using.
Yeah, I'm using earphone.
हाँ ठीक है, अभी आ रहा है, अभी it's coming. Okay.
Better?
So now, it's better. So this is the negative history which you have taken. Okay. So have you taken any history for aspiration as such?
Yes, sir. There is a chronic cough.
There is no history of cough
Aspiration
while
actually I didn't
swallowing.
mention, sir, because
No issues. Okay, you should remember why you have taken the negative
Okay.
history. So the point number 4 that you have mentioned, that
Yes.
no history of cough while swallowing, it indicates that there is no aspiration as of now in the patient. Okay.
Aspiration.
What is this blood in sputum, evening rise of temperature, night sweat indicates?
yes, sir. Tuberculosis, sir.
Tuberculosis. Okay. So it's very common in our country. You have to rule out by this symptoms and all.
Yeah.
ठीक है. Move ahead to the next slide.
Yeah.
Okay,
Passes.
so here,
There's
so
no
here
issue,
you are,
case of
yeah,
hypertension.
okay, not an issue. We read that. So you are saying that this patient is a BD smoker, and so is there any significance of smoking with laryngeal malignancy?
Yes, sir. Actually, yes, sir. Actually, BD smoker, that is smoking is increasing the chance of getting laryngeal carcinoma, sir.
Mm-hmm. So do you have any data to back
Laryngeal
it up?
carcinoma and hyperpharyngeal carcinoma. Even. Yes, sir. That I say I don't remember, sir.
So I'll share you this. Yeah. Exactly. है ना? So this theory you have to remember. I'll share this PDF. Read it again. It's from Scout only. And okay. So this you have to remember. And it's basically, if you back up your anything with any data, so that generally it's a better thing. Okay. So I'll tell you just a minute.
Yes, sir.
Okay, so generally it says that if your pack years are more, basically, so if your pack years are more, the odds ratio for the malignancy increases. And they even, this study mentions that if your pack years are less than 20, so that odds ratio is 1.5 to 2, whereas if this pack year is more than 20, this odds ratio goes up till 3 or 4 also. Okay, and next very common question, in personal history, you have mentioned any uptake about alcohol?
Yes, sir. But there is no history of alcohol, so he's not.
So you mention it because as soon as you will say there is no history of alcohol, so next question will come, what is the importance of alcohol along with smoking?
So it increases the
Yeah,
absorption
alcohol
of
increases the absorption of the.
So there is a specific word which you have to mention. Try somebody.
Synergistic action.
This alcohol has a synergistic action along with smoking. Okay, so यहाँ पे there are again 2 more Viva questions which I would like to take it here only. First thing is try it out. What are the effects of alcohol along with smoking? There are 3-4 points, important points which you should remember. One, Dr. already told that alcohol acts as a solvent for the carcinogens of. क्या हो गया? Ashish, you have not. Okay. So first thing Dr. already told that alcohol acts as a solvent for the carcinogens of smoking. Now anything else apart from this? एक solvent वाले part के अलावा anything else?
Upgradation of enzyme to cytokine.
Alcohol decreases the immunity.
Yes. Second point also correct that it alters the enzymes. Third is that alcohol
Also
lowers the
decreases the
immunity.
appetite.
3. चौथा?
Decreases the appetite.
Yes, appetite. That is also good. Then there will be one point that the product of alcohol is acetaldehyde. Okay, so this acetaldehyde also is like toxic. Okay, and last point also you have to remember that generally in alcoholic patients, क्या हो गया? Points again, helpful. Dr. Dipangshi.
Just read the points.
Okay, not an issue. I'll share the whole PDF also. I'll share it in the end. Like there might be some things which I'll miss, with something which you will miss. Not an issue. I'll share the PDF. See, 5 points you have to remember. The first line which you will say is that alcohol has a synergistic action. These are the words which have. I'll say these are the keywords. Okay, so which have good impact. So you have to say that alcohol has synergistic action along when taken along with the smoking thing. Second point is alcohol acts as a solvent for the carcinogens of जो आपके smoking में carcinogens है. Third point में you will get that upregulation of the cytochrome enzymes which alcohol does. Fourth point is that the product of alcohol that we studied in organic chemistry कि alcohol से acetaldehyde बनेगा. So that acetaldehyde also is toxic. Okay. And fifth is the alcohol reduces the immunity of the patient per se, and generally the patients who are alcoholic, they have this vitamin and all the deficiencies which make a person more prone to getting malignancy. So these points are from Scott Brown itself, please remember it. And in Scott Brown also, they even mention this data also that when you stop smoking, what is the relative risk that you will get cancer after 5 years. So data you have to remember, just Scott, nothing else. Okay, I'll share that screenshot at the end in the PDF.
Okay, sir.
Okay, so remember how to calculate pack years, BD years also. We had shared in the group. Appetite normal, mixed diet, bowel, bladder, sleep normal. So move to the next slide. Acha, one more thing. For smoking, you told na. Can you are there any forms of smoking which you would like to elaborate over here?
Smokeless tobacco.
Smokeless tobacco. Not please tell. Smokeless tobacco is linked with which type of malignancy more? Is it laryngeal or something else?
Oral cavity.
Oral cavity is no answer, bhai. There is no answer called as oral cavity. You have to mention some side. Okay.
Hypocarcinoma.
Yes, hypopharyngeal carcinoma. Smokeless tobacco generally is linked with hypopharyngeal carcinoma. This is a generalized term. Now coming to specifics. Pipe smoking is related to lip carcinoma. Okay. Then one more question which is asked is reverse smoking. Reverse smoking that is linked to hard palate carcinoma. Palatal carcinoma or hard palate carcinoma. Then third thing is there is something called as Khani. Okay, people from UP Bihar belt will relate to it. So what they do is they take that tobacco ball, mix it with lime and all, and they place it in the gingivo-buccal sulcus, GBS. So GBS malignancy is common in people who use this kind of tobacco. Then fourth question will come is what are the carcinogens, Dr. Sir, that you are saying in they are present in tobacco? So first answer will be nicotine. अब nicotine के आगे क्या बोलोगे?
Benzpyrene, nitrosamines, polycyclic aromatic hydrocarbons.
Yes, Dr. Saab, है ना? Put it in on group again. After the class gets over, put it on group again so that it becomes helpful for everybody. Okay. So we have discussed about tobacco. We discussed about alcohol over here. Okay. Chalo, move ahead to the next slide. ठीक है. No family history. Do you know any familial cancers or familial syndromes which run in family, not related to larynx?
Fanconi's anemia.
Good. Anything else?
Bloom syndrome.
Bloom syndrome.
Bloom syndrome. Yes.
Ataxia telangiectasia.
Ataxia telangiectasia. Good. Very good. Thank you. सब लिख लिया. 4, 5 थे all there. Same paragraph of Scott Brown. You have done it correctly. Okay. Move ahead. Drug history you have told. Okay. Move ahead. Okay. So you have come to diagnosis. The laryngeal growth under evaluation, query malignant in a known case of hypertension till now. Guys, just give me a minute. There's a call coming. Just a minute, please. Just.
Can anyone repeat once? So family history में क्या बोला था? Fanconi's and
Bloom syndrome, Fanconi's anemia, Ataxia telangiectasia.
okay, pause.
These syndromes are associated with laryngeal CA, right?
No,
Yes,
this
yes.
was asked in journal.
Sorry, guys. Just an important call. Couldn't avoid it. You were saying something. Didn't get the answer. Mila?
So, sir, is these syndromes which we have told just now, is that associated with laryngeal CA?
No, not associated exactly larynx. These are seen in the oral cavity malignancy. ठीक है, CA tongue में they'll be asked. ठीक है, but since all these things are related by the method of field cancerization, so this can be asked in this section also, not related to directly to CA larynx. ठीक है, चलो move ahead to the you have mentioned the diagnosis. Okay, go to the I'll not this diagnosis na last में summary when we will discuss, then we'll like see the points which are important. Okay. Start.
General physical examination. Conscious. The patient is conscious and alert, and to time and place in person. And the patient is cerebral and moderately well nourished. And BP is 134/80 mmHg and SpO2 99% in room air. Pulse rate is 102 beats per minute, and ECOG grading is 2, and Karnofsky is 80.
What is this ECOG you have written?
It's 2.
oncology.
Yeah. Please, Dr. Puneet, please repeat once again for everyone's benefit.
Eastern Committee of Oncology Group.
ठीक है, so this individual ECOG का full form has already come as a OSCE for 1 marks. ठीक है, it is a question already being asked. Okay, so remember the full form, remember the grades. Okay, now next question which will come is what is the importance of these performance scales? Dr. Sridhar?
Sir, it's basically to decide what kind of treatment we can give to the patient. It depends upon the radio as well as the salvage treatment, surgery, whether patient can manage after this.
Good. And second thing is like when the patient comes to us for follow-up, so it will act as an indicator what kind of like has it degraded it down or better, and also as a medical legal document. Okay, so and second question which about a tip from my side, don't mention both of them. Okay, mention only one which is being followed at your institute. Like in my hospital, we used to mention only ECOG. So I'm familiar with ECOG. But Karnofsky, you have to learn for exam purpose. Now, what advantage it will give you after completion, after you say, sir, ki ECOG score is so-and-so, just look at the examiner and very likely he will ask you what is ECOG, what are the gradings, why it is 2, and then he will ask you, do you know any other grading apart from ECOG? So then you can Karnofsky, you can just put it in front of him. Okay, so if you will utter everything from your side, so you are not giving examiner to ask easy question, so he will ask difficult question. तो जहाँ पे हम लोग फंस जाएंगे, ठीक है? So this is my suggestion to you guys. Okay. So we did ECOG हो गया, Karnofsky हो गया. Please remember the details of ECOG and Karnofsky. Okay. Move ahead to the next slide.
And during general examination, there is no pallor, recurrence, clubbing, cyanosis, edema, and lymphadenopathy. And come to systemic examination, center CNS, CVS, RS, and abdomen examination, everything looks
okay. Second tip over here only.
And come to ENT examination.
Just a minute. See, you mentioned about lymphadenopathy is absent. So make sure कि lymphadenopathy is absent here also, and when you examine the neck, so वहाँ पे neck notes should be negative. There should not be disparity because this is out of rectification we write this pickle is negative, and वहाँ पे neck notes में we'll be writing कि 2 into 1 centimeter node positive 1B. Getting my point? Thank you.
Okay.
ठीक है. So this make a note of it कि there should not be disparity in both the things. Okay. So you have mentioned this is negative, systemic examination is negative. Come to specific local examination.
Come to local examination, oral cavity and oral pharynx. Mouth opening is adequate, 3 finger, and lips, gums, teeth, GBS, and gingiva buccal circus, gingiva labia circus, hard palate, tongue, floor, everything looks normal. And oral pharynx, soft palate pillars, tonsil, fossa,
one advice again over here. Oral cavity examination should be mentioned separately. Oropharyngeal examination should be mentioned separately. Should not be clubbed together. Okay, one. Second thing is, what is the importance of, you said mouth opening is adequate. How is it relevant to you?
Sir, it's usually normally we keep the 4 fingers, sir. 4 fingers, the patient's fingers we keep vertically.
Okay.
Okay, and if it is the WHO criteria, it comes.
Importance. I'm not asking you to classify trismus. Importance क्या है?
हाँ sir, yeah. Importance whether it is involved this thing like TMJ as well as pterygoid muscles. Sir.
Okay. Anything else?
And oral for submucosal fibrosis and the examination of oral cavity, and if you want to do any scopies, it will be helpful.
Plan the treatment
yes. So
surgeries.
Exactly. Na? So these all 4 points will be asked. Why is this trismus important? Now coming to the next point, you asked history of lips, gums, teeth. So what kind of teeth will you be looking at?
Whether it is any loose tooth.
Loose tooth, yes, doctor. And now comes the second question, what is the importance of loose tooth?
So, loose tooth, there are two things. When we are examined during the direct laryngoscopy, there's a loose tooth, you can mislodge and it can become a foreign body. That's one thing. And second thing, post-operative, if you are giving a radiation, it can end up to the osteoradio necrosis.
Yes.
And if there is any impending infection, that can lead to further delay in recovery.
Correct. All these questions are correct. Now, fourth point you have already mentioned. Oral cavity and oropharynx should be separate. Come to the next slide. Okay.
Sir,
what is
exophatic growth. Yeah. So ideal we did, sir. And the exophatic growth. Hello.
Continue.
Yeah, sir. Ideal we did. There's a exophatic growth visualized over left vocal fold, extending over its entire length, and the left and that vocal cord is not mobile. And left hemilarynx fixer, and right true and false vocal cords appear everything normal and it's mobile. And the glottic chink is reduced. And other part, vallecula, base of tongue, and piriform fossa, everything looks normal. And we could see the tracheal ring also, it's normal. Subglottic level also, it's normal, sir.
Okay, good. So, you have drawn this diagram. So, there were many queries about this thing. What to go about ideal, how not to go about ideal. One thing is that this thing is the most basic investigation. Like we are not doing these days in our OPD because we have our Hopkins endoscope in our hand and nasal endoscope in our hand. But please practice doing this ideal at least once before you enter the exam hall. Okay, carry your ideal mirror along with you. I know it's difficult. It will be difficult, just to get the exact findings. Okay. Second thing is carry you, if possible, if you have your portable endoscopes, carry along with you, and the faculty over there, which is there, just ask them, sir, can I use this after doing my ideal examination? If they allow, just do it, and this will give you confidence on the drawing which you have drawn. Okay. And see, the thing is, nobody will penalize you for I'll say that this anterior commissure is not involved, or you are not able to comment upon the involvement just on the basis of ideal examination. Ideal examination is just for the thyroid case, these are the steps: T3, T4, TSH, ultrasound, and Bethesda, FNAC. So similarly, ideal is one of the stones or stepping stones for reaching the diagnosis, how to manage the patient. So you should know how to draw the diagram. Your findings, whatever you are saying, should support whatever you have drawn, and it should not be exactly gross. Growth is there in the left PFS and you have drawn it in the right PFS. So that is little bit problematic. And you have mentioned about hemilarynx fixed, right, true, and false vocal cord appear normal. Okay. Go ahead to the next slide.
Neck examination, sir. Trachea is midline and laryngeal capillaries is present, and no palpable swelling or lymph nodes are present, sir.
Okay. So over here comes the most common question, which if larynx question comes, everybody of you will get. What is this laryngeal crepitus, Dr. Saab?
Laryngeal crepitus is the cracking sound which is made by the which is rubbing cricoid over the body of the cervical vertebrae, sir.
Okay. And if it is present, what does that mean? And when it is absent, what does that mean?
Yeah, if it is present, that is normal, sir. If it is absent, there are two things: either any soft tissue growth over the cricoid or in the retropharyngeal prevertebral area, sir. Any inflammation.
Prevertebral area. Everyone, please remember there is a lot of confusion what to answer for this. I also had this confusion. We used to answer post-cricoid. The post-cricoid region when there is some growth in the post-cricoid region, laryngeal crepitus will be absent. Nahi hai. I saw around 3-4 presentations before this, today's session. They are specifically looking for this word prevertebral region. Okay, so when your growth goes and invades the prevertebral region, that your cricoid will not be able to rub against the vertebra, and hence that laryngeal crepitus will be absent. Okay, so this is an important thing. Please remember. Now you have told no palpable swelling, lymph nodes not present. Okay, So lymph nodes will be seen in which type of subsite malignancy of larynx?
Mostly in supraglottis, sir.
Okay. In glottis, will you see lymph node enlargement at early stage?
Early stage we won't see, sir.
This is important question. ठीक है कि glottis में lymph node enlargement in early stages is not ये. And do you remember what lymph nodes drain, like for supraglottis which level lymph nodes, and for glottis and for subglottis which level nodes are there?
Supraglottis is 2 and 3, sir. And
2, 3, 4.
2, 3, 4. And the glottis usually the retropharyngeal and paratracheal lymph nodes.
Glottis में mentioned that in the glottis they mentioned that initial may it's not seen, but in later stage 3, 4, 6 can be there. And subglottis?
Subglottis is 3 and 4, sir. And
subglottis 6 and 4.
No, it's number 6.
Okay, so for that sixth lymph node, is there any node name for that lymph node?
Delphian node.
Delphian node. And the Scott Brown mentions another name for this Delphian node?
Nodes of Rouvier.
Pretracheal.
Poirier slip.
Boyer's slip.
Poirier's.
Okay, this I'll have to, yeah. Poirier's, right?
Yeah, Poirier's prelaryngeal lymph node.
Yeah, Poirier's lymph node. Please put it in group also, right? For everybody's, yeah. ठीक है. ठीक है. Chalo, we saw these three things. Then
And ear examination and pre-auricular pinna post-auricular.
here only, just a minute, right? Here only, please read embryology of supraglottis, glottis, and subglottis. They might take this, take viva from here only to the embryology. That why is it different in supraglottis? Why is it different in glottis? So you have to mention the branchial arch theory. Read about it. I know it's very boring, but for exam purpose, just read it once. And how the supraglottis develops from the third and fourth branchial arch, and how the glottis and subglottis takes place. What is the watershed area? I'm not just taking you. I'm just briefing you. All these things, please read it once. Okay. And then there is a very common term that is called as transglottic growth. So what do you mean by transglottic growth?
Transglottic involve usually arises from the glottis, sir, and involving supraglottis as well as the subglottis part.
Okay, so it crosses the ventricles basically.
Yes, sir.
Okay. Okay, this you have told. Okay. Anything else that you have to mention?
Here there is no sinus, no scar in the neck, sir.
ठीक है, not relevant. आगे चलो.
Yeah. And come to ear examination and nose examination, sir. Everything looks normal, sir.
ठीक है. So if it comes as a long case, present like full. Don't
Yes,
leave
sir.
anything behind. But if it comes as a short case, so you can go ahead with the like important findings. Okay. So
Okay.
anything else? Do you have next slide? कुछ है? Yeah, thank you.
Yes, sir. Diagnosis, sir.
Diagnosis है. Okay. No
Sir,
short forms to be used. No short forms to be used in your exam. Okay.
Okay.
Right.
Yeah.
Full everywhere. चलो बताओ क्या लिखा है?
Yes, it's a case of carcinoma glottosupraglottis in a non-case of hypertension, sir. Come
Okay.
to E3, N0, M0, comes stage 3.
Okay. So one more tip, like from my side, like if I would be attempting the exam, I would never give two diagnoses in one question. Glottosupraglottis. ठीक है? My like one easier way as a resident will be you start with one thing. Sir, this is a malignancy from so and so thing, and which might be extending in the supraglottis or in the subglottis depending upon your possible interpretation. Okay.
Okay.
Second question which can come over here is why you are saying it is T3. Okay. And third question will be staging. Please remember the staging. Supraglottis staging is different, glottis is different, subglottis is different, but unfortunately you have to remember all of them. Okay.
Yes, sir.
Apart from this, you have to remember staging of thyroid, nice and proper, staging of NPC, nice and proper, and same goes for the CA tongue staging. And fourth thing will be hypopharynx. Fourth will be obviously you say everything is covered. What is the fun? But that's how things go in practicals. You have to remember everything. And nodal stage and staging of NPC is very important. They have specifically asked this to describe this end staging of NPC. Okay, so when you read this nasopharyngeal carcinoma, please read the end staging specifically. T तो ठीक है, but end आपको याद रखना है. ठीक है?
Okay, sir. Yeah.
So you have mentioned the diagnosis. Please correct it accordingly and read for the viva according to these points. Now this patient is there with you. Now what do you plan or what do you intend to do with the patient? How will you approach him?
Sir, this is a case of a carcinoma glottis. So first we have to confirm the diagnosis. Okay, so we have to take a biopsy, sir. So
Okay.
before taking biopsy, we will do all the blood investigation.
Okay.
And we'll take to direct laryngoscopy and take a biopsy.
So before biopsy, will you do anything? या सीधे OT ले जाओगे पकड़ के?
Imaging we can do, sir. Yeah.
Yes. What kind of imaging would you like to do for the patient?
CT, sir.
CT scan. CT scan. Okay. Contrast enhanced. Huh?
Flexible fiber optic laryngopharyngeal.
Flexible fiber optic stroboscopy we can do.
Yes, you can add it in your investigations, but read about it if you are saying these things. Okay. So standard is like you will do a Hopkins endoscopy or FOL, whatever you want to say. There's a difference between when to do FOL, when to do DL-scopy, when to do DL-scopy. And for imaging, now I wanted to land you up in the imaging sequence.
Okay.
Doctor, when you will do CT, and next question is when will you do MRI for the patient? For laryngeal pathology, I'm saying.
Yeah, if there is a advanced disease, sir, whether it is involving the esophagus, and if it is involving the prevertebral area, then only we'll consider to check the extent for. Then only we'll do a MRI. Otherwise, it is enough.
Okay. So generally, 2-3 points are there. Doctor, we couldn't get you. Please repeat, sir.
If the cartilage invasion is suspecting, then we'll do MRI first.
Yes, bilkul. है ना? So there are 3-4 points that you have to remember. For cartilage erosion, CT is specific, but MRI is sensitive, highly sensitive. Okay. Second point that will be there is, like, I'll first tell you about MRI. So MRI is generally used in the early laryngeal malignancies, in early cartilage involvement if you want to detect, and if you are like suspecting prevertebral fascia involvement, like delicate things, so you can go for the MRI thing. Whereas in the CT will help you in seeing the cartilage erosion. Okay, CT will help you in seeing the extralaryngeal spread through the cricothyroid membrane, whatever like spread is there. And two things are there. Ki generally, the thickness which you get in CT is around 0.6 mm, whereas in MRI we get sections of around 4 mm. And CT also helps us in doing the local staging and rule out the distant mets. Generally, क्या होता है? Larynx के mets, where do they go? Like suppose you are saying glottis cancer is there. So glottis cancer का second primary कहाँ जाता है? Lungs. Okay, so when you will be doing a scan for this patient, you will do CCT of base of skull to thorax, like complete you will do. So generally you will rule out that second primary. Okay, so this is also a beneficial factor for the. And third thing is. One question again related here. As we just saw, glottic carcinoma second primary is in lungs. In hypopharyngeal carcinoma, where is the second primary which goes?
Esophagus.
So remember it. Okay. So these two words remember. CA glottis, second primary is in lungs, and hypopharyngeal it is in esophagus. So we saw difference between CT and MRI.
Okay, sir.
Then we'll do DL-scopy. Okay.
Yes.
So what do we get in DL-scopy? What extra advantage is there in DL-scopy?
Sir, DL-scopy, we can examine all the area and as well as the mobility of the joints.
Area say we come to the question hidden area. What are the hidden areas of larynx?
Hidden areas start from the laryngeal surface of the epiglottis, and it comes up piriform sinus and postcricoid area, and subglottis and anterior commissure.
Okay. Remember it?
Ventricle undersurface of two vocal cords.
Yes. Bilkul. Undersurface of ventricle. So remember this question. This question will also be asked as what are the differences between ideal and direct laryngoscopy. Okay.
Yes.
So apart from the inverted image and voila concept, these things are important part of that answer. Okay. So you will do DL-scopy. So DL-scopy, you have seen the areas of larynx. Anything else?
Sir, we palpate the joints, sir, arytenoids.
Okay.
Whether the mobility is present or not.
Okay. And then you will do mapping of the growth, and then you will. Now suppose, Dr. Sahab, your patient was having T4 malignancy, and there was like glottic chink was very less. Okay. So what counseling will you give to the patient before surgery? Before DL-scopy only, not surgery. Before DL-scopy only.
Yes, sir. Actually, because of the glottic chink is very less, it's very difficult to do a direct laryngoscopy in one stanza. So I will advise for the elective tracheostomy, sir.
Yes. and supposedly like you have not done elective tracheostomy, and as soon as you enter your DL scope, the patient starts desaturating.
Then we can intubate through the DL scope and then shift for the.
Yes, Dr. You have read all the Viva questions. Good. Now, supposedly, a patient is unlucky, and remember this question also, that in these cases, what kind of tracheostomy will you do? So, generally, we do a high tracheostomy for the patients, keeping in account the total laryngectomy, which is the surgery to be followed. Now, supposedly, the patient is T4. Why I'm saying T4? Because your Viva will more commonly start from this T4 wala thing. T1, T2, T3 will just, these are theoretical things. Read the theory from that. What is the management for T1, T2 and T3? We'll start with T4 over here. That is like extra laryngeal spread ke saath the malignancy which has come. So the patient gets the diagnosis of squamous cell CA of larynx. Okay. So what will you plan for the patient?
For T4, sir? Okay. For this case, if it is a T4, I would have planned hemilaryngectomy we can plan, sir.
Okay.
Consider it because
why hemi over here?
Sir, because the opposite side of vocal cord is intact.
Total.
Okay. ठीक है. So यहाँ पे your whole Viva will revolve around near total laryngectomy, hemilaryngectomy, what are the OPLs, what are the VPLs, है ना? So yes, read about that. And when what generally happens is like what I saw during my residency and the post-residency time, कि generally the common surgery which is performed is total laryngectomy. This is my opinion, which I have seen. So this is in Viva also, people take you to take your thought process about the total laryngectomy wala thing. Okay, so remember what are the indications for total laryngectomy? One. Then you have to remember what are the process procedure steps for total laryngectomy. 2. Third will be what is the post-op care, what are the complications for total laryngectomy. 4. And then the most important part which you have to read, that is rehab after total laryngectomy. Okay, so because this is the more common part where the more common the Viva questions are asked, that's why I'm discussing this thing. For your theory practical purposes, please read the T1, T2 and T3 wala jo theory hai. Just go through it once so that there is something about that in your mind. Okay, so this question can come that supposedly you have planned total laryngectomy for the patient. Counsel the patient. How will you counsel the patient? This question can be asked in Viva, if you get this as case. This can be asked in a ward round also. Here is a patient and you have to counsel him for total laryngectomy. And similar thing, counseling station can be there as a spotter in OSCE. So doctor, how will you counsel the patient for total laryngectomy? What all will you tell to the patient?
Sir, actually, I have to explain about the disease as well as the disease progression if you don't do the treatment. And second thing, we have to explain what procedure we have to do. Then I have to explain about the post-surgery rehabilitation. No, I have to explain about the complication of the surgeries.
Okay.
And I have to explain the functionality of the larynx after surgery. There won't be any function. And the rehabilitation also. And a permanent tracheostomy.
Okay.
Okay, and rehabilitation, and speech. As well as
yes, that's what I'm asking. So, in the common terms, how will you explain? Like you told the generalized scientific term that you will explain the functionality, functional status of larynx. But to a common layman, how will you counsel him? What are the 3-4 points that you will tell him that how will his life change after total laryngectomy?
Okay, actually, the breathing he has to depend upon the external tube, the tracheostomy tube. Then for the speech, he has to depend upon any other artificial larynx or tracheoesophageal. We'll put another processes which are connected to the esophagus. Like that way, he has to speak by closing the tracheostomy tube. And second thing. And third thing, his smell as well as the taste, everything will be reduced or altered. As well as there is a high chance of getting recurrent infections in the nose. Okay.
And one more last point is
Loss of cough reflex.
Loss of cough reflex. That will be there, and he will not be able to do swimming. No smell. Swimming will be banned for the patient. Don't go for swimming around. These things will be there. And 5th point is cost that you have to explain to the patient.
Yes,
okay.
Yes.
Follow up you have to explain to the patient. one TEP, है ना? So it is a like I'll say huge amount in like those people who work in government setup. So for them it's okay, like you get the supplies. But for like people working from the corporate setup or the like private setup, so everything the patient has to bear up. So that those all things you have to explain to the patient. Like post-op surgery, mein, all these things can become like can be there, and the charges which are to be incurred by the patient. Follow-up has to be explained, and then there's one question that he might ask you: is there any other option available to me? Okay, so that you have to explain, and followed by that, any adjuvant therapy if you are planning, that you have to explain for the explain to the patient. It's like we generally plan like RT or CTRT for the patient, adjuvant therapy. So that you have to explain to the patient. Okay. So these things. So supposedly like you have planned a total laryngectomy for the patient. Okay, and you have done all the pre-op workup, and I'm not going into the steps. Please remember the like main steps. Okay, main steps of surgery. What is the name of incision for total laryngectomy?
Glux Sorensen incision.
Glux Sorensen incision. It's an individual of skin itself. Okay, like Glux Sorensen incision. How will you go about the surgery? That is okay. Then you created the stoma. You created the primary TEP. Supposedly you took the primary TEP. And
Sir, can you name the incision again?
Glux Sorensen incision. Okay, I'll just post it on group. A minute. ये तो he might also ask you who was teacher in them and who was the student. So there is a story behind the Glux Sorensen incision. Read on Google. Acha. So you have performed a total laryngectomy for the patient, and after like what are the complications that you expect during the surgery?
During the surgery, sir?
During surgery, post-op surgery, like complications, what do you expect?
Yeah, sir. Immediate complications. First thing is start with bleeding only, sir. And
Hemorrhage,
second,
okay.
Yeah, hemorrhage, as well as then is pharyngocutaneous fistula.
Okay.
Okay. Then in seroma, sir.
Supposedly you land up in evening rounds mein gaye. What do you like will be worried? Any electrolytes?
Hematomas.
Chyle leak is there, hematoma is there, calcium level is there. ठीक है, तो all these things you have to worry. Okay. ठीक है. अच्छा, just another question. Like, is there any danger of RLN injury for total laryngectomy?
No, sir.
Yes, remember it. Okay? It's a very common mistake which we do. What are the complications? So we just remember that thyroid wala, we remember it. So we just blurt it out, give RLN injury. So doctor, we are removing the entire larynx, so everything has gone. So there is no danger to that. So this is a mistake we generally do out of, I'll say, stress of exam. So that's why I repeated this question deliberately. Okay. So you told about chyle leak, you told about seroma, you told about hematoma. Okay. Chyle leak. So for chyle leak, how will you manage the patient?
Sir, immediate post-operative, within 24 hours, if it is coming more than 1000 ml, then more than 650, more than 1000 ml, sir. And we have to re-explore.
Okay.
But if it is a low flow, we can manage conservatively by giving the pressure as well as reducing the fat content.
Fat and triglyceride diet. Any drug you remember for managing chyle leak?
Octreotide, sir.
Octreotide. Yeah. Good.
Then we can give the
ठीक है. Then you have managed the patient accordingly. You have seen for pharyngocutaneous fistula and ठीक है. And for the TEP, when it comes to TEP, what precautions will you take for TEP? In the post-op period.
Sir. Basically,
whatever you have done in your hospital, just remember and repeat. No point of learning.
Sir, TEP we have to remove. We are supposed to remove and clean it properly.
Okay, you remove it entirely and clean up. Like we were very afraid. So hum to like antifungal solutions we used to clean it. Like whatever you have been following in your institution, repeat it. Okay, but this might be a question. Okay, what are the causes for blocking of TEP?
Blocking of TEP, one itself, the TEP itself can get damaged. One thing.
Yes.
And second thing, because of our cricopharyngeal myotomy, cricopharyngeal spasm, sir.
Yes, cricopharyngeal spasm. That I was wanted to ask. How will you relieve this cricopharyngeal spasm? Any
botulinum toxin?
We can give the Botox, sir. As well as
this is post-op. Pre-op mein, sorry, not pre-op. Intra-op mein anything which you can do?
Myotomy.
Cricopharyngeal myotomy. ठीक है, cricopharyngeal myotomy can be done, and then followed by that, like if it still is there, these kind of things are there, so आप botox दे सकते हैं. ठीक है, you have done these things. Okay, and ठीक है, I think we have covered most of the things. Let me just check once anything is remaining question. हाँ, इसके बाद आपका your question will come. Like you have already placed TP for the patient. So okay, so like these things you will voice rehab आपने कर दिया. Any other rehab which you can do for the patient?
Olfaction rehabilitation.
Psychological olfaction.
हाँ, एक करके थोड़ा olfaction के बारे में please like enlighten somewhat please.
Polite yawning techniques.
हाँ, है ना? So please, there are two maneuvers if I'm not wrong. I'm just forgetting the name. हाँ, बोलो, you are saying it correct. बोलिए.
Sir, olfactory testing, we had to olfactory like retraining therapy, sir.
Retraining therapy. ठीक है. Okay, ठीक है. And supposedly, there is a very, I'll say, feared complication. There's something called a stomal recurrence.
Yes, sir.
Do you know any named classification for stomal recurrence?
Sisson
Classification.
Yeah, there are two classifications.
Atiyah
One is by the name of
classification.
Sisson's classification, and second is Atiyah and Sisson's classification. Okay, so both of them are individual questions in them. So please remember it. And okay. So doctor, please repeat once again.
Swallowing rehabilitation also there.
Swallowing rehab. Okay, so I request iska na whatever rehab data you guys have got na, please share it on group. It will be a revision for everyone else. There will be few of them who might not be having it and still I don't know, like might not have asked about it or might not have read. It will be helpful for everyone. Okay, so in the initial part I started and told ki there is some data in Scott Brown and I've just got it. I'll repeat it and after that I'll share it in the group also. It says that laryngeal carcinoma is related to smoking and alcohol use, and the risk in smoker and drinker is 177 times higher than the non-smoker and non-drinker. So remember this data. So what happens in Viva, if you utter any number and you back it up, ki bhai Scott Brown mein it is written, so it gives a very good impression and you tend to get better marks as compared to your counterparts. Now, second figure which I would like you to remember is that again in this chapter of in the head and neck section, chapter number 20, it's there that there is a strong association between laryngeal cancer and cigarette smoking. We saw all those things, but remember the words of Scott Brown. It says that the relative risk of laryngeal cancer between smoker and non-smoker is 15.5 in men and 12.4 in women. So if you utter this data number, that 15.5 is there in the men relative risk and 12.4 in women, it helps you in getting more marks. Okay. Second Viva question which can come is ki laryngeal cancer is associated with what are the etiologies? We have read multiple etiology about the oral cavity cancer. Like these are the 5 S of oral cavity. As a laryngeal cancer ki etiology ke liye, please remember exposure to nickel and mustard gas. One. Second is asbestos exposure. ये देखो group पे I am sending. Just read it once. Only one paragraph. Okay. So it is associated with nickel and mustard exposure. One. Second is asbestos. They might ask you this question: ki why is what is the importance of occupation of the patient? So you can this third point will help you that the car mechanics are at increased risk. The people who work in battery plants, they have increased risk. People who have exposure to radiation and all, they have increased risk. Okay. And one syndrome that you have to remember over here is your Plummer-Vinson or the PBK syndrome. This can be asked in the OSCE also. What are the related factors of these PBK syndromes? Okay. And remaining, I'll share it with you. Subsides of larynx, please remember. Stages of larynx, please remember. And we have already seen these things. Okay. So, Dr. Saab, over here, I'll rest my case. I know it is not very in-depth presentation, but my intent was not to increase your knowledge. The intent of this class was that you start from point A and you read point Z and you reach the discussion part. So that if you are through that thing, you are getting more than 50% marks in that case. That is for sure. And remaining thing will depend upon your knowledge, what you have read over the time. Okay, and the questions also I have repeated. Please go through these things. Familial syndromes. Acha, Dr. Ashish has already written it. Okay. ठीक है डॉक्टर साहब. So any point from your side? Else we'll meet again with case presentation on thyroid on 28th. ये कब है? आज Tuesday होगा, Thursday को. ठीक है. We'll again meet with this thyroid case presentation. Doctor साहब, you're writing something? लिखो. Stomal recurrence classification, there are two names. One by the name of Sisson classification, second is Sisson and Atiha classification. है ना? Somebody please share a screenshot and write both the names. Okay. So that last point. कि we are into the last week, है ना? Hardly 7-8 days are left. So just keep on pushing yourself daily. Okay, divide your times in all the three aspects, because if you will not divide, your mind will, there will be brain fogging to you. Okay, so you will feel that I'm reading but I'm not able to concentrate and all. So daily give 2 hours for your 2 hours for the theory, the main case that you want to take. Then similarly 1 to 2 hours for the OSCE. Revise the old OSCEs, revise the important topics, important images that we have seen and from your own notes. And similarly, the theory, please don't forget to read theory. The problem which we face is that we theory नहीं पढ़ते हैं, because everything is a theory only. And so, like the day, like the way you had revised it for your theory exams, similarly 2-3 hours daily revise whatever notes you have, whatever books you have followed. It will help you during the exam. Third point is, please make that PDF / page where you keep on writing your problematic areas. These are the areas which I likely tend to forget. So at the end, you will be having around 10-15 topics. So these topics, please revise at the last day of the exam. Okay. And this is a genuine year from, like, we are almost a strength of 100 plus as of now. So please help each other. That's all I can say. I got my center in one hospital in Mumbai, and like the fear which we had going to a new place, totally alien environment, I don't know what's going to happen. Okay, and so if like someone helps us from the institute, like to just make us comfortable, what cases are there, how you will go about it, so it will generally it calms the mind. Okay, so whatever possible, please help each other. That's how things go. And ठीक है डॉक्टर साहब. There's one more question. During counseling session, should we talk as if we are talking to the patient, or explain to the examiner what all we will tell in the counseling? See डॉक्टर साहब, see if examiner says कि भाई talk to the patient, like supposedly if the same thing comes to you as a long case, so patient will not go along with you to the examiner. You will walk to the examiner along with the case sheet. So वहाँ पे तो examiner will ask you only कि what you will tell. So just keep on speaking, and this can happen in the ward rounds. What you are saying, कि ward rounds में there is a person sitting over there. Examiner says कि he has got T4 and counsel him for total laryngectomy. So then you have to talk to the patient, and examiner is listening to you. And when this thing is there, you have to add 2, 3, 4 things. The first is wish the patient good morning, good evening, namaste, whatever you want to say. Tell your name, कि I am Dr. Saab. Today is my exam. I want to this is your thing. Then explain whatever you want to tell him, and finally ask his doubts and end it with a thank you. So all these things count in the counseling station if it is there. And in the case discussion, how did we come to conclusion? It is glottosupraglottic. See, Dr. Saab had mentioned he would have taken from somewhere. So that's why he had mentioned that both of things are there. My take will be, go with this thing only, go with one thing only. सबसे easy है, if the patient is coming with the primary complaint of dysphonia, hoarseness of voice, stick to glottis. ठीक है? And like if you are seeing something else in your ideal, you can say that the growth is primarily arising from the vocal cords and going up to the supraglottis. And if the patient is coming with complaints of dysphagia and other complaints, so then you can include the malignancy of supraglottis. एक साथ दो, this is my personal opinion. Don't include two things at one position. As a resident, give simple answers, and simple discussion will lead you more than 50-60% marks, and you'll easily pass the exam. चलो, anything else? Any other message? नहीं. ठीक है डॉक्टर साहब. ठीक है. No. हाँ. अच्छा. Good. है ना? We'll meet on Thursday again. है ना? Discussion on thyroid and routine discussions that we go about. We will keep on continuing. Whatever questions you also get, please post in the group. That will be helpful for yourself also and for everyone else also. Because these kind of discussions, the more you discuss, more are the likelihood that you will remember. जितना आप अकेले पढ़ोगे, more are the likelihood you will get confused, you will get bored, you will get scared, उसके बाद आप बंद करके छोड़ दोगे. So keep on discussing with your colleagues, your co-PG, your juniors, and let's hope for the best for the last 1 week. Don't fall sick. Okay, so take all the precautions. It's an important thing. One of my seniors, this thing happened with him. Very much studious, very good theory exam, too fantastic. But unfortunately, he had some sickness before the practical exam, and the practical exam did not go as well as he had expected. So these things happen in real life. Last 5-6 days are there. Avoid unnecessary things which can hamper your health. And let's hope for the best. I hope you would have booked your tickets by now. Reach timely. ठीक है, डोंट डू दिस नॉनसेंस कि मैं मतलब लास्ट फ्लाइट पकड़ के जा रहा हूँ, लास्ट फ्लाइट छूट गया तो फिर गया 6 महीना. ठीक है, तो टेक सम अर्लियर फ्लाइट, टेक सम अर्लियर ट्रेन, रीच टाइमली. ठीक है, टेक अ लोकेशन व्हिच इज नियरर टू योर सेंटर. डोंट स्टे 25 किलोमीटर्स अवे फ्रॉम द सेंटर. ट्रैफिक में फंस जाओगे सुबह, हो गया मुंबई एंड बैंगलोर पीपल, मुंबई बैंगलोर एंड चेन्नई गाइस. ठीक है, so you will get stuck in traffic, so things will go honky ponky, and फिर क्या होगा, adrenaline rush होगा. Whatever you are knowing also you will make it wrong in the OSCE. ठीक है, so reach the exam center a day prior, see it, don't rely on Google ये 2 किलोमीटर दूर है. एक दिन पहले you go there and see center की like how far it is from your center. Okay, and reach timely, have breakfast, all those things. I'll again keep on pushing you, and chalo, all the best. We still 2-3 sessions are left. Good night.
Good night, sir. Good night.